with the West House Hospital Trust, and has kindly agreed to come and talk to us about our bones. So if we can, welcome him to the talk. Thank you for coming, Mr. Watson. Over to you.
Thank you very much. Good afternoon, ladies and gentlemen. As you heard, I'm an orthopaedic surgeon. I work here at Watford and St Albans and have all part of the West Herts group. And I'm a surgeon, and I deal primarily with hips and knees, but also other joints in the body as well. And don't worry too much about the slides. Some of them are adapted from talks that I've given to GPs. Some of them have got a little bit too much information on them. But the main thing is, I'll talk about all the things that I'm interested in, and then you can ask me any questions you like about anything that you may have, any questions you may have about your bones and joints. I've got a limited amount of time, and I can't examine everybody and prescribe medicines for you and treat you, but which is what tends to happen. But I will do my best to answer all your questions, or any burning questions you have about your bones and joints. A little bit about me. I trained in London, and then I did my orthopaedic training at Stanmore, and I spent a year in Australia learning some specialised hip and knee surgery there. There is a test at the end, so make sure that you... and the things that I'm particularly interested in are hip replacements, knee replacements, keyhole surgery, trying to get people's joints back to working again without doing anything too major. And there's one extra thing which I thought you might be interested to know about, which is a service that we offer on the NHS at West Herts, which is shockwave therapy, which is very useful for certain muscular and tendon type problems, and I'll just tell you a bit about that at the end. So, knee and hip pain, that's the main thing I thought I'd talk to you about, because it's so common. 25% of people over the age of 50, and I don't mean to be rude, but I'm guessing we're in that sort of age group here. And about 12%, because that means that one quarter of this room at least has pain in their knee, and at least a tenth of you has pain in your hip. So it's common, so we need to talk about it. And what can we do about it? So, although I'm a surgeon, when I see someone who's got pain in their hip or their knee, the first thing I think about is not, I need to get you into the operating theatre and open you up. Okay, you'll be pleased to know that. There are simple things that we do first which work brilliantly before we do anything else. And the first thing we say to anyone is lifestyle changes. Okay, so that slide I think says it all. You don't really want to be the person on the left eating the large burger. You want to be the person on the left cycling. Weight is a major issue, and I don't lecture my patients because I know how difficult it is to lose weight. But you've got to think about it. When you walk, you're putting weight through your joints, and all your weight has to go all the way down to the tips of your feet. And when you go up and down stairs, up to 8 times your body weight can go through your knees. So even a normal person, we say is 70 kilograms, or whatever, say, just for argument's sake, say 8 stone. That means that you can put up to 64 stone through your knees when you go up and down stairs. So obviously the more weight you put on, the harder it is for your knees to work. And so we tend to try to just get people to eat a bit healthier, move around a bit more. Just gentle exercise can really make a big difference. Painkillers. There's no harm in taking painkillers. I've got lots of patients that say to me, oh, I don't like taking the pills, I don't like taking them, they mask the pain, or they interfere with my other drugs. But the truth is, and I want you to know that if you do have pain in joints, paracetamol is very, very safe. It doesn't interact with any other drugs, pretty much. As long as you stick to the dose, which is 2 tablets up to 4 times a day, it will not have any effect on any other part of your body, and it will help your pain. And codeine, we can add to that. Sometimes people find that paracetamol codeine bums them up a bit, so it's not for everybody. You probably know. But I advise people to take lots of fluid with it if you're taking codeine. And then the anti-inflammatories like ibuprofen and Voltarol, not everyone can take them because they can irritate their stomach. But if they don't, then they're good and they work. And that can be enough. And the last drug I put there, I don't always prescribe it, it's called tramadol, but it can knock you out. It's very good pain relief, but it can knock you out of it. But if you need it, then you need it, and there's no crime in taking these things. Glucosamine. I put this up because everyone always asks me about glucosamine. Has anyone heard of that?
Yeah.
Yeah. They sell it, they try and sell it to you all the time, tell you that it's good for joints and this and that and the other. I don't know. The truth is, there's no science that actually says that these things are good for you. There's no trials that really show a difference. The big trials that have looked at all the little trials show that there's no difference whether you take it or not. But I do have patients that swear by it, and there's probably someone in this room that swears by it, that they take it, they can feel a difference. And because it's safe, it doesn't cause, it's just a food supplement, because it doesn't cause any harm. I tell people, take it for 3 months. If it doesn't work, save the money that you would have spent on it and go on holiday. because the warm weather, because it's not cheap, this stuff, it's quite expensive. And if you don't find that it works for you, don't take it, save your money. I think that's the best advice. But if you find that it does work, and I can't argue with that, you know, and people do swear by things like cod liver oil and other supplements, and if you can get them cheaply, and the cheapest place to buy them is the back of the Sunday papers, where you send off for a year's supply for a £5, then fine. If you can afford it, that's fine. But if you don't think it's working, don't waste your money. Physiotherapy. We can always organise physiotherapy for you. Some places it helps just to keep the joints supple, to show you a few exercises, keep the weight off it, strengthen the muscles around the knee or the hip, help you walk and show you how to use a stick. Physiotherapists are really helpful. The ones we have locally are fantastic. Injections. So now we're getting on to a little bit more invasive. There are 2 sorts of injections that we can offer people for any joints. It's not just knees, there can be shoulders or hips. And the steroids is the most common one. Everyone's heard of cortisone. Everyone goes, oh no, not cortisone, it hurts. So my friend had it and they were in agony for ages afterwards. I don't want that, don't want that. What I can say, in my hands, it's not particularly uncomfortable. They do work. They do take your pain away. But the problem with them is that it's how long they last. Because some people find that they last a day, some people find they last a week. I've got patients that it lasts a year. It's very unpredictable. Most people reckon it's about 3 to 6 months. And then the next thing I've written here is quite a long word, viscose supplementation. That's jelly injections, where we can inject a filler into the joint. Really, it's just for knees, but they're starting to use it on other joints. And it's like a thick stuff that acts like a shock absorber, so it coats the inside of the knee, and it gives a bit of shock absorbing ability to the knee, and it probably lasts a bit longer than the steroids. It's quite expensive, but we do have it on the NHS. And your knee really has to be the right sort of knee for it, and we will gauge whether it's appropriate for you or not. Usually we have to perform it in the operating theatre, even though it's just an injection. And that's just because the government won't pay for it unless it's an operation, because it's quite expensive. Surgery. Surgery is the last resort, okay? We only offer surgery if we've tried everything else. So you've tried some physiotherapy, you've taken your painkillers, despite all that, oh gosh, my knee hurts, my hip hurts. Despite all that, only then do we think about operating on people. And there are different kinds of surgery. This is just a picture showing keyhole surgery. I'm sorry, some people don't like these kind of pictures, but you're asleep for it, you don't feel it. And why I think we make little tiny holes around the joint, and we look inside with a telescope, and we can clean out the joint, we can smooth it out, we can take away bits of torn cartilage. Sometimes people have things called loose bodies, those loose bits of bone that have broken off as a result of the wear and tear. And we can clean all of that out, and it feels great afterwards. You usually do this as a day case, so you're in and out the same day if we do it. You don't need to stay in hospital the night, and you can usually get up and go, walk straight away afterwards. We usually put plenty of pain, we put lots of anaesthetic in, so it's not too uncomfortable when you wake up. And the way I do it, I don't even put any stitches in, the cuts are so small. You just have a bandage. But that's only for certain conditions. So these are sort of things I'm saying we do. And the other thing I can do is reconstruct ligaments. If the ligaments are torn, we can do that through keyhole surgery as well. And we can do things to try and encourage scar tissue to cover the raw part of the bone that's worn away. It's all quite clever, and it's relatively simple and straightforward. We don't get many complications with that kind of surgery. But if all else fails and a joint is really worn out, and we need to get you going again like this lady, at any age, then joint replacement surgery is the answer. And that's really what I enjoy and my sort of area of expertise. And the thing is, we've got new things that we can give to people that should last for a lot longer. In the old days, when I started training, we wouldn't do joint replacements on anyone until they were pretty old, or if they were really, really, really bad, because of the reason that they only lasted a limited lifespan. They could last about 10 years and they wore out because they were made of metal and plastic. But now I brought some props to show you, and I don't have these around. So now we have these things which are ceramics and implants that go into the bone. These haven't been in anyone, so don't worry. So this goes down the thigh bone, and it's coated with this white chemical, which the bone sees it as bone, and it grows into it, and this actually becomes part of the bone. It doesn't wear out, it doesn't loosen. And then the bits that rub against each other, we have these pink things. They're ceramic. I mean, it's really, really hard, and the joint lubricates it. And you'll feel, because I have these around, but even without the lubrication, it's actually very, very smooth. And I'll put this back in here. And again, this here goes into the normal socket, and it's coated with a material that grows into the bone. And because that becomes part of the bone, and because the parts that rub against each other don't really wear out because they're so hard, I can't say for sure because they've only been going for 20 years, but they shouldn't wear out. And so for that reason, we can do these at any age. It's still a big operation, we still don't do it willy-nilly, but we don't worry so much about them wearing out. So whatever age you are, if you need it, and we would do it. So if you want to have a look at these, so you can pass those around. And then, similarly, I'll show you something else to go around as well. This is a knee replacement. So in a knee that's completely worn out, what we can do is open up the knee, just smooth away the ends of the joints, and we have specialised things that just exactly fit to how we cut them, on exactly your size. I'm trying to sell them. And then we get an artificial knee that moves like a normal knee. And although this is metal and plastic, these plastics are very, very modern, and they don't wear out the same way that the old ones do. You can pass those as well. And then we have other sorts of bearings as well, highly polished metal things which rub against each other. And also, we have the ability to just replace parts of the joint. So where it is a knee replacement, if one side of the knee is all right, we can actually just leave it alone and just put a filler, just put a patch on the bad side. So either just that side, or if, say, the middle part of the knee is worn out, we can add something to that as well. I won't pass this one out, it's a little bit flimsy, but we can tailor-make the operations now. Instead of sort of one size, if your knee's gone, you just replace the whole knee, you can actually just replace parts of the knee, which is a much smaller operation. And should this wear out, then we can replace it with one of those full knees, which is fantastic. We've moved on quite a lot. Don't worry, it's pretty durable.